Good morning, everyone. My name is Kirsten Nuckless. I'm a Senior Policy Analyst with the Department of Health and Wellness and a member of the Diversity Committee. It is my great pleasure to introduce Ms. Stacey Lewis. Stacey has been a project manager with the Dwegan Partnership, a partnership of the 5 Unama'ki bands. Unama'ki is the traditional Mi'kmaq word for Cape Breton. And the Dwegan Partnership is aimed at achieving health outcomes that are equal to or better than the Canadian population. And prior to joining the Dwegan Partnership, Stacey was an educator and also worked for a number of organizations dedicated to population health promotion through community development. So without any further ado, I would welcome Stacey to come up and provide us with some very insightful and interesting information as she provides a presentation on telling our stories, collaborating to improve information about First Nations health. Thank you.
Thank you, Kirsten. Good morning, everyone. I'm really happy to be here. This is my very first Health Equity Forum. So I'm very much looking forward to the presentations and the discussions throughout the day. And it's my pleasure to be here to share with you some experiences that I've had with a collaboration over the past 5-6 years around First Nations health information. And there's some people who were here at the very beginning of the collaboration. We were getting letters of support and things like that. So it's exciting to be at this point and actually have some successes to share. So for my presentation, I'm just going to get used to this flicker here. I'm going to start with a very brief introduction to the Dwegan Partnership. I'm going to describe the Telling Our Stories initiative, not in great detail, but give you some highlights. I'm going to share some of the lessons learned about collaboration through that project, and then talk a little bit about how the collaboration has grown and some of the exciting things that are happening today. So Dwegan, as Kirsten mentioned, is a health partnership of the 5 Unama'ki, or Cape Breton First Nations, which includes Eskizoni, Member 2, Bodeladek, which some people know as Chapel Island, Wagmacook, and Wegoma. And the partnership actually formed back in 2004. And since that time, the 5 communities have collaborated on over 30 healthcare initiatives. And they run the gamut, everything from primary health care renewal to cancer patient navigation, some mental health and addictions, shared initiatives, tobacco reduction, maternal and child health. And as Kirsten mentioned, the vision of the partnership is to achieve health outcomes that are equal to or better than the Canadian population. No small order. So a little bit about the Unama'ki communities. The combined population of the 5 communities is 8,000 people. The largest community would be Eskizoni, where there's close to 4,000 people, and the smallest would be Bodeladek, with around 700 people or so. In contrast to the rest of the province, our communities are younging, we're not aging, and we have a very high birth weight, lots of babies. There's a very high burden of disease and disability. No surprise, chronic diseases like diabetes are very prevalent. And in each community, there are band-run health centers, which provide the bulk of primary health care and public health services to the populations. So one of the areas that Dwegan has spent a lot of time focusing on is health information. Like many diverse groups, it can be very difficult to find good information about the health of First Nations people, not just in Nova Scotia, but across the country. And as they say, knowledge is power. Without good health information, it's very difficult to know how the health of First Nations compares to the rest of the province. It's difficult to identify where the health inequities are and how to address those health inequities. In Unama'ki, there is a long oral tradition, which is alive and well, and for many, many years, the communities have been telling the story of their people's health. But the language of stories is not always the language of funders. So having good numbers, good statistics, helps the communities tell their stories in a language that funders can sometimes better relate to. So by filling in some of the information gaps, the communities have been able to make better decisions about how to spend limited healthcare resources and how to identify services that the communities will need in the future. So several years ago, the Unama'ki communities decided to try to do something about those gaps in health information. And in 2008, with project funding from Health Canada, they launched the Telling Our Stories project, which was focused on improving information about the health of First Nations in Cape Breton. And the partners in that project were the 5 Cape Breton First Nations, the Nova Scotia Department of Health and Wellness, primarily through BIAP, the Business Intelligence, Analytics and Privacy Unit, Cancer Care Nova Scotia, Reproductive Care Program of Nova Scotia, Cardiovascular Health Nova Scotia, the First Nations and Inuit Health Branch of Health Canada, Dalhousie University, their Population Health Research Unit, GASHA, and CBDHA. So as a group, we were aware that the province, like all provinces in Canada, collects a wide variety of health data. For example, physician billing data, hospital discharge data. The provincial health programs have a variety of data sources, cancer registry, the Atlee perinatal database. And all of that data is routinely used by the department and by district health authorities to monitor the health of Nova Scotians and to plan and evaluate health services. What we needed to figure out was how to use that readily available data to provide the Unama'ki communities with better information about the health of First Nations people in Cape Breton. And as with anything worth doing, there were a number of challenges. The first challenge was a technical one. There are no reliable First Nations identifiers in provincial health data sources. So our first challenge was try to figure out a way to delineate the Unama'ki population within those broader data sets. So our solution was to create a registry, a population registry of the Unama'ki communities that could somehow be linked with those provincial health data sources. That sounds easy? Not so much. This is a diagram of our registry creation process. So let me just walk you through each of the steps in this diagram. I'm just kidding. I like to say we put 3 different sources of data into a big pot, stirred it up, and then out came a registry, but that drives the epidemiologist nuts. So I'll give you just a very boiled down version of what we did, no pun intended. We used demographic data from the electronic medical record systems in each of the 5 communities to identify people who were receiving care at the health centers. We used data from the federal government's Indian Registry System, which is a registry of all status Indians in the country. We used that Indian Registry System to identify members of the 5 Cape Breton bands. We linked those 2 data sources to create the Unama'ki Client Registry and added a provincially recognized identifier, the health card number, which came out of the Nova Scotia Health Card Number Registry. The key piece in our population registry, in this Unama'ki Client Registry, is the health card number. It's the health card number that allows us or enables us to link with those provincial health data sources and pull out information for the Unama'ki communities. What I just described in 30 seconds took us about a year to design. It was tremendously complicated, but not nearly as complicated as the privacy and governance challenges that we would face. So, this was the piece I think that we were probably the least prepared to deal with. To create the registry, there were a number of authorizations and agreements that were required. And so the first was a data sharing agreement between the 5 bands and the province of Nova Scotia. And this was completely uncharted waters. There was no precedent to follow. So we were building something from scratch. We needed approvals from a number of data access committees and research ethics committees. We needed approval from INAC's ATIP office. We needed 15 separate band council resolutions, 2 service level agreements, and 3 data use authorization agreements. They were good times, good times. For the First Nations partners, it was really important that the registry creation process and the registry governance model adhere to OHCAT principles. So for people who aren't familiar with OHCAT principles, they're a set of principles that guide how First Nations data can and should be used. They were developed about 15 years ago in response to a long history of mismanagement and misuse of First Nations data. And OHCAP stands for Ownership, Control, Access, and Possession. So for the First Nations partners, it was really important that they own the registry and that they control who gets access to the registry. At the same time, we recognized the registry was made up of data from various sources, including the health card number. So our data governance models had to respect the Department of Health's responsibilities and legal obligations around the health card number. I'm going fast because I got the sign. We also had to make sure that individual and community privacy were protected in both the registry creation design and in the governance model. So we had to ensure that everything was compliant with provincial privacy legislation, which at the time was FOIPOP. There was no VIA. We had to complete a comprehensive privacy impact assessment, which we call the BRIC. It's like 200 pages long, and our PIA consultant said it was the most complex PIA they had ever done. In the end, we were able to agree on a registry governance model and a registry creation process that adhered to both OHCAT principles and provincial privacy requirements. And these are enshrined in our data management policies and procedures. So we were able to work through all of those technical and privacy challenges and develop our registry. So this is when we started working quite closely with a number of provincial health programs in the Population Health Research Unit at Dalhousie. It's at that point we started to work with them to select health indicators that would be useful and helpful to the communities. And those provincial programs and FRU linked our registry with their data sources, and they developed a number of wonderful health indicator reports on a variety of issues. We've got demographic data, we've got maternal and infant health data, cancer and cervical cancer screening data, lots of good information around heart attack and congestive heart failure, demographics, health service utilization, chronic disease patterns. So I don't have the time to go through some of the, all of the data, but I thought I'd present just some of the highlights so that you get a sense of what kind of information is in those reports. So we learned that diabetes prevalence is 3 times the provincial rate, and the onset of the disease occurs at a much younger age. We knew that the prevalence rates were high. We didn't know they were that high. Heart disease rates are much higher in Unama'ki communities than in Nova Scotia, and again, onset occurs at a much younger age. Even though there's a higher level of chronic disease, people in Unama'ki visit specialists less often than other Nova Scotians. Breastfeeding initiation rates are going up. That's good news. They're actually quite close to the CBDHA rate. Prenatal smoking rates are 2 times the provincial rate, so we have lots of work to do there. Children have lower rates of respiratory conditions than the rest of Nova Scotia. Again, more good news. And a big surprise, one of the most common causes of avoidable hospital admissions is dental conditions. Nobody expected that one. So we're actually partnering now with some folks at Dalhousie to try to do a little bit of investigation around that. So what difference does having this information make? We have a much better picture of the health of people in Unama'ki. It's certainly not a complete picture, but we have more pieces of the puzzle. We are developing tools to share that information with community members, with political leaders, and with our healthcare partners. And so back in June, actually, we released 4 health information bulletins with some highlights from those rather detailed technical reports. This is the cover of our cancer health bulletin. This is the cover of our health service utilization bulletin. We've had a really good response to these. The information is being used by the communities to develop their health plans, to set targets and to measure progress towards those targets. And we're using the information to start a dialogue around how we can improve the health of people in Unama'ki. We learned a lot about collaboration throughout that process. We learned that it's really important to take the time to build relationships and mutual understanding. And there are things that will happen outside of your process that will affect relationships. That's just always going to happen. We learned that it's really important to have champions, people with the right connections at the table, so people who can take issues back to their respective organizations and move it through the appropriate channels. And you need problem solvers, people who, when they see a barrier or a challenge, can work together to try to come up with some solutions. Political will. Can't say enough about political will. None of this would have happened if we didn't have the support of chiefs and councils, if we didn't have the support of the Minister of Health or senior leadership within Department of Health at the time. Formalize agreements to ensure long-term commitment. And that can be a bit of a challenging process. We move from very informal relationships to formalized relationships that are set out in legal agreements. And nothing can kill a relationship quite like legal negotiations. So, because it forces you to look at the what ifs. What if something happens? You look at potentially ugly situations and you start thinking about how you carve up assets, and whether it's intellectual property or funds or whatever. So you have to kind of ask those hard questions and think about how you would work through that stuff. So I'm happy to say that we survived the legal negotiations and with the relationship still intact. We learned that you have to be patient, you have to persevere, and you have to remain optimistic. We had a lot of pep talks. We had dream big, build on past experiences, but not limit the possibilities. We had to map out a realistic timeline when you are involved in a project that's based on collaboration. Double your timeline, because it takes time and you can't rush relationship building. And you have to have a sense of humor. So the future looks bright. The collaboration has grown since 2011. Dwegan was successful in obtaining funding from Health Canada about 1.5 years ago to expand the registry. We are expanding it to interested mainland bands. So right now we have 12 of the 13 Nova Scotia bands on board. We are exploring new partnerships with some new provincial health programs. So we'll continue to work with the ones we've worked with in the past, but we're hoping to work with the breast cancer screening program, renal program, and a number of others. So the future looks bright, and if you have any questions, I'd be happy to take them. Thank you.
My name is Daryl Collins, and I am the Senior Records Analyst for the Department of Health and Wellness, and I am also a member of the Diversity Committee. Today, it's my pleasure to have finally met Charlie McDonald, who I've heard a lot about. And Charlie has over 35 years' experience with the Nova Scotia Public Service. Charlie worked for 15 years as a civil engineer in the Planning Division of the Nova Scotia Department of Transportation, and 15 years as an Executive Director for the Nova Scotia Department of Disabled Persons. This is a mouthful. Charlie most recently was the Senior Diversity Consultant with the Nova Scotia Public Service Commission, where he provided leadership to the province's diversity initiative. Currently, Charlie is the coordinator for the Nova Scotia Persons with Disability Employability Table. The table provides guidance to the Department of Labour and Advanced Education in promoting the employment of persons with disabilities in support of the Nova Scotia Workforce Strategy. Not finished. Charlie has a master's in business administration and a bachelor of civil engineering. He is blind and travels with his guide dog, Cosby. So Charlie, I'd like to welcome you to the podium, please.
I think we're in business.
Oh, it's great to see some familiar faces and friends. I've discovered in the last couple of weeks that my dog is more famous than I am. But he made the paper, but anyway. Ann and I are going to do a presentation on a couple of models of collaboration that may be of interest to you. The first one being the Nova Scotia Persons with Disabilities Employability Table. And then Ann is going to speak to the Government Community Committee on the Transformation of Services to Persons with Disabilities program. So there may be some learnings from both. And I'm going to hopefully get Ann to do my slides. Are you all set?
Yep.
So if I could have the
Next one.
second slide, I guess.
There you go.
Just a little bit of background on the employability table. There are 4 tables. There's a Aboriginal table, African Nova Scotia table, an Acadian table, and Persons with Disabilities table, all funded through the Department of Labor and Advanced Education. In establishing the table, there's a little bit of background. It was falls under, with the transfer of labor market development agreement resources from the federal government, labor market agreement, monies that we've all heard of over the past 2 months, it seems, or a year, and renegotiating that. But in the transfer, it was identified that certain groups have a particular stake and are significantly disadvantaged in the labor force, and that they should be encouraged to collaborate, to come together and inform the department on how that can be improved, the representation of Aboriginal persons, African Nova Scotians, Acadian people, and people with disabilities in the labor force. As they transformed into Employment Nova Scotia, and as they transformed a previously federally driven Employment Assistance Service to a Nova Scotia-driven Employment Assistance Service, Employment Nova Scotia. So it was through that process that the table was started, and it was begun in a very collaborative way. Ann was involved in the initial days where the community was called together of all the disability community organizations that have a stake, an interest, a passion around the employment of people with disabilities. So a facilitated session was held around what a body would look like, who should be a member, where it should be situated, should it be in government, should it be a community organization, what would the terms of reference of that group be, a fairly blank page really of we want this to happen, community, you tell us how it should happen. So through a facilitated process, it was agreed that terms of reference were developed. Organizations and representation from organizations were agreed upon, and it was a fairly what I would call loose, very long but very loose terms of reference. So everybody could see themselves or have a role in the committee. So how decisions were made really built on consensus and a gradient of agreement. There was no, well, now here's our membership, no one else can join. It was if others see the benefit of becoming involved, they can join. If people want to be virtual members, they can participate virtually by email, etc. So it was agreed. The committee was established. It was agreed that it best fit outside of government. And then where does it sit outside of government? How do we determine where the contract sits? So an RFP was called for. Organizations responded, and Teamwork Cooperative was selected as the place for the contract to sit, and it was off to the races at that point. Coordinator was hired, and it was developed, started to develop. One of the major issues that certainly identified to me and was of concern through the first little bit of the work of the table was what the heck, you have a terms of reference, but what really is the mandate? What mandate has Labor and Advanced Education given the committee, et cetera? So there was, probably in the early days, there was a little bit of, well, what is the mandate, and did it change every month? Did it change every year? But once it was pretty much nailed down that this indeed is the mandate of the table, things progressed a little bit more smoothly. And I believe the next slide is the mandate.
Yep.
And this is it basically in a nutshell. That was certainly agreed upon by Labor and Advanced Education, agreed upon by members of the committee. And in thinking back, it was through the evolution of the Jobs Here document and building the Nova Scotia workforce strategy. So really the mandate is defined as the table making recommendations on strategies that would improve the representation of persons with disabilities in the labor force. I mean, basically, that's what it came down to. We would have had an add-on to that through the period of building the Nova Scotia workforce strategy to inform and support persons with disabilities participating in the Nova Scotia workforce strategy. So that was the essence, and that's particularly helpful to have a clear mandate so the work can be focused on that. The next slide just gives you a little overview of the membership. A very diverse membership on the table, representing employment assistance service providers that provide services to people with disabilities. Some of the vocational service centers, adult service centers, supported by community services were members through the Directions Council for Vocational Services, the Collaborative Partnership Network, and then single disability organizations that may either be providing service delivery or maybe indeed just advocacy organizations for specific disabilities. So it ranged from, for example, Autism Nova Scotia, Independent Living Nova Scotia, CNIB, Society of Deaf and Hard of Hearing Nova Scotians, just a broad range of organizations that have a stake in the employment of persons with disabilities. So we also had government reps at the table. The Nova Scotia Community College, for example, key stakeholder, representation from the Department of Labor and Advanced Education, as well as the labor market agreement for people with disabilities. So it was a very, let's put it this way, there was a variety of agendas at the table. And everybody recognized that. So building, as the previous speaker mentioned, trust, providing an opportunity for people to speak and feel supported in what they said, not being judged, developing that rapport, that ability to focus on the identified problem. And what was the identified problem? I think the next slide is just a very snippet, Anne, of what we know about people with disabilities in Nova Scotia.
Yep.
It is an urgent issue. We have the highest rate of disability in the country, and we have a very low labor force participation rate. 52% of people with disabilities in Nova Scotia of working age are not employed. 55,000 Nova Scotians of working age are not employed. And then when you look individually within that demographic, certainly people with developmental disabilities have a very low labor market participation rate of under 30%. If you have a severe or significant disability, your chances of being unemployed compared to other people with disabilities is double. Certainly folks with intellectual disabilities have the lowest labor force participation rate of any disability group in the country. And I mean, there's other statistics that we've developed that we could share. So for example, people who are blind, the unemployment and not in the labor force rate is 70%. So a significant social and economic issue that we face. So that's the essence of what our challenge was. The next one is everybody brought their own personal, the next slide, Anne? Yep. Thank you. The next slide, everybody brought a little bit of their own personal and professional understanding of the disability community. So whether you worked as a service provider, whether you worked as in a disability organization, everybody seemed to have a common understanding about what are the barriers to labor force participation. And then we did research. We did a significant Canada-wide, worldwide research on trying to identify what the barriers and are there common themes. And people could really roll up their sleeves on that work and provide, as I said, their own personal, professional experience to that, but also looking at the literature, looking at what's happening in the US, what's happening in Australia, what's happening in the United Kingdom. Are there similarities? And indeed there were. And this slide just gives you a quick overview of what are the major barriers. And these are the themes. It's the myths and stereotypes that employers have about people with disabilities, that supervisors, managers, and even fellow employees have of people with disabilities. It's lack of accommodation, support services that enable people with disabilities to be employed. It's inappropriate service delivery models and poor employment assistance service for people with disabilities. you can put up a shingle and open an organization and say you're a disability organization, you know, understand everything about disability X. But what's truly needed within the employment component is organizations that understand business needs, that can make the connection between understanding skills shortage, understanding what employers need, and making that connection with their knowledge of disability. So that's identified as an issue. Certainly inflexibility in the income assistance service is a major issue in the system. Difficulty transitioning from high school to employment or post-secondary employment was identified as a major issue. And again, of course, transportation and housing. So the number of themes were identified and they were repeated over and over again. And that was very helpful to the work of the table, because that's directed us as to what we could do to better move the agenda forward. So informing the transformation of the service of the Employment Nova Scotia service sector was a major important initiative of the table. So every step of the way as Career Nova Scotia was established, certainly disability and the issue of disability was an important agenda topic for the table, informing the department on that. Certainly engaging with employers and trying to dispel the myths. So whether it was collaborating with the Canadian manufacturers and exporters, even the Irving Shipbuilding and the Irving Shipbuilding Center of Excellence, and even broadly speaking, I guess even the Capital District Health Authority, of getting establishing relationships with the service provider sector and trying to support and promote the employment of people with disabilities. So as the work evolved, we did a number of things, ranging from establishing the Ability Employers Association, really promoting the annual symposium on inclusive employment and education with the Ability Starts Here, Join the Conversation, From Conversation to Action, a number of initiatives like that. As we complete our mandate, we're releasing what we call a blueprint for action for the equitable employment of people with disabilities. This was a collaboration of the table. I think the next one is just, is it a quote?
Food for thought.
Food for thought. This is a quote from the It's Now or Never that I picked out and will appear on our blueprint for action. And really it's not about do we need to change, it's how do we change. And that's what the blueprint will address, and trying to connect the work of the table and the blueprint to the Commission's report. Next one is, we had core assumptions, and we identified these early on, and these were very helpful. What are our core assumptions as a collaboration? And the first one's very important. It's the health, well-being, and economic prosperity of Nova Scotia requires the participation of everyone. So that's connecting the health, social, and economic. And that was bought in by everyone. So having that common understanding of what our core assumptions are. And again, some of them I think are self-evident around the UN Convention on the Charter, UN Convention on the Rights of People with Disabilities, our human rights legislation. They do provide for equity and equality, but that just doesn't happen. There has to be proactive measures to ensure that equity and equality. So even having an understanding that the assumption that people with disabilities should be employed is a basic assumption that we have. That it's not you leave high school and then you sit at home, or you go to a sheltered situation, or we'll look after you. It's let's start with the assumption that everyone should be employed. So those, and again, core assumption is that leadership, collaboration, and partnerships are a critical component to the solution. So we did identify a vision. I think it's the next one.
Yeah.
And that was very helpful early on of identifying what is our shared vision. And our shared vision, because of the eclectic nature of the group, it was around the service sector, it was around the employer sector, and then an overarching vision of people with disabilities participate equitably in the Nova Scotia labor force and achieve economic self-independence. So the first one is around service sector excellence. The second one is around disability confidence, or employers having the tools, understanding the business case for supporting people with disabilities. So everybody bought into the vision, everybody created the vision. The next one is we had common values, shared values, common principles, and they're in a way self-evident, but we did spend a lot of time on these of agreeing. We had what we called a gradient of agreement, which is trying to build consensus on even the wording of these, and that was very helpful. So totally supportive of it. I can live with it. I don't like it. It's absolutely terrible. That kind of concept, and mostly it was everybody agreed or could live with it. And some of them, I think, you'd pretty much be self-evident around inclusion, equity, equitable representation, service excellence, et cetera. So that was very helpful. And then the next slide is the blueprint. The blueprint. So we've worked on a blueprint for the last 2 years as the table matured and developed relationships, and we'd bring guest speakers in to inform the blueprint. We had the tripartite social committee in to talk about their report on the health of Aboriginal persons and try to tease out an employment component to that and what work has to be done around the employment of Aboriginal persons with disabilities in Nova Scotia. We'd bring in speakers from the Advisory Council on the Status of Women, other sectors on social enterprise, on entrepreneurship for people with disabilities. Just a broad process of building a blueprint, of building what we see as the future of how we can turn this ship around and become more representation. The next slide just shows you, we broke it into pillars. It's at the printers now, so we'll be releasing it in the next couple of weeks. But it has an overarching recommendation which really speaks to the need for a national strategy. And that comes from a lot of presentations that have been made nationally through the Standing Committee on Human Rights and the Status of People with Disabilities. But we have 5 pillars. And those 5 pillars include, pillar 1 is, it has to be identified as a priority in Nova Scotia by the government of Nova Scotia, the employment of people with disabilities. And that has several recommendations under it, including, for example, becoming a more representative public service, accessibility legislation for Nova Scotians with disabilities, supporting entrepreneurship and social enterprise, et cetera. The second pillar speaks to the need for people with disabilities to develop the skills and have the supports they need to be employed. And that goes into a wide range of workplace essential skills recommendations, of supporting students transitioning from school to work. The third, am I running out of time?
Well, they just said to wrap up, but you're.
Okay, because Ann has.
You're getting close.
Okay. I'm trying to barrel through here. And this is the service sector. So you'd be interested to note that in this recommendation for the service sector, with the changing demographics of Nova Scotia, cultural competence training for employment assistance service providers working in the disability field should be mandatory. So it's in recommendations like that. The fourth pillar is around a social marketing initiative, an ability starts here challenge for employers, providing them with the tools, but also challenging them to hire people with disabilities. And the fifth pillar is access to the competitive labor force, having the supported employment model that is supported and in place so that people with disabilities, irrespective of the nature of the disability, can achieve employment. So that's our end game, and thank you. And Ann, do you want to?
I'm going to try to do 2 things at once here. So Charlie and I both actually sat on the joint Nova Scotia Government Community Advisory Committee on Transforming Services for Persons with Disabilities. And it was really a true privilege to be on this committee. It was, in some ways, I think, pretty groundbreaking. So I'm going to go through the process in terms of how the committee was set up and what the committee was able to achieve. In terms of a bit of a background, we were involved with helping to establish a disability framework for the province. I work at the Disabled Persons Commission. I took over from him when he left the Disabled Persons Commission. And one of the things I was really keen to see was a provincial disability strategy for the province. And the previous government agreed to look at 10 strategies that they had underway and to make sure that people with disabilities were engaged in those strategies and to ensure that whatever was created with those strategies would be inclusive of people with disabilities. And there was a real desire to ensure that true engagement did take place through the development of the strategies. One of those strategies, or one of the pieces of work, was to look at ways that continuing care and services for persons with disabilities could work more closely together to create sort of a seamless service between the two 2 program. So that work was underway, and we were involved with ensuring, again, that any consultations that took place, that people with disabilities would be able to take place. And several consultations were held across the province where lots and lots of people with disability came out to talk about their experiences with both the continuing care program and services for persons with disabilities. And it was during that time that there was also some work being done to look at how the Services for Persons with Disabilities program within community services could be transformed. And it was agreed by the previous government that that was a priority of theirs. So they agreed that an engagement process had to be created that would include the disability community. So to start things off, what happened was they created a design group that brought together people with disabilities and representatives from government to create the terms of reference for the committee. How would this work proceed? So it was a one-day meeting, and at that meeting we looked over a draft terms of reference and made comments to that and gave input to that. The process was created for how the transformation committee would be established, who would be on it, how many representatives would there be from various groups, and so we all had input into that. And there was an agreement that Lynn Hartwell, who was then the Associate Deputy Minister of Community Services, now the Deputy Minister of Community Services, would be one of the co-chairs, and it was also agreed that there would be an additional co-chair from the community, and we had input into what would be the criteria for selecting that individual. So then the joint advisory group was established. Letters went out to a variety of groups. And groups were told, you can choose who you want your representative to be. So from the community, the Nova Scotia Association for Community Living was on there. The Nova Scotia Disability Strategy Partnership Group had 2 representatives. Community Homes Action Group had a rep. People First Nova Scotia. There was a mental health advocate. Organized labor was involved. It's easier to read off of here than on the screen. So we had a frontline worker from the Regional Residential Services Group was on there, and then we had several people from various service providers on the committee. And then, of course, government. You can see the various representatives that were there. So it was a very broad advisory group. And it was amazing because not only was it broad, but you had people who came into that room with different positions on various issues. And I can honestly say, when we started it, I didn't know how it was actually gonna go. But in fact, everybody came with the same desire to see the system transformed, and so it was really easy to be pretty collaborative in a lot of ways in this instance. The other key piece to this that's not on the slide is that it was agreed that the group that would facilitate the sessions for us was IRIS, which was, I never get their title proper, but they are a think tank, if you will, and have done a lot of work around deinstitutionalization of people with disabilities. And so 2 of their members, Don Gallant and Dr. Michael Bach, they actually were the facilitators for the session and for all of our meetings and did a fantastic job. In terms of the objectives, I'll go through them quickly for the SPD engagement. We were tasked with developing a roadmap for transforming the Nova Scotia Services for Persons with Disabilities program. We were very much guided by the UN Convention on the Rights of Persons with Disabilities, and really what we were striving for were the following outcome: to adopt a person-centered focus to programming, enhance and expand community-based care, reduce reliance on institution-based care, increase the integration and coordination with other services and programs. As I mentioned earlier, a big piece of it was the continuing care and SPD collaboration, and ensure financial sustainability. Objective 2 was in developing this roadmap to identify promising practices from other jurisdictions and from the Nova Scotia experience. And again, Iris did a fantastic job of doing a lot of that groundwork for us, and coming back with best practices from a variety of places. Objective 3, we wanted to ensure that through the lens of the UN Convention on the Rights of Persons with Disabilities, that we really paid attention to the various roles and responsibilities that everybody would have to play. Be sure to ensure that community-based residential, day, and vocational employment support service delivery mechanisms were based on the principles of person-centered community inclusion and, labor force participation. Getting back to what Charlie said earlier, have to come from the place of that everybody can work, and then creating systems that will enable that to happen. Outcome 4 was to identify short, medium, and long-term outcomes and benchmarks for guiding the work. Initially, we were hopeful that the work of transforming SPD could take place over about a 5-year, but realistically, it's really going to be about a 10-year plan for getting the work done. And outcome 5 was to recommend immediate short-term steps to trigger the transformation process, and there really were 3 initiatives that started right away. One was to come up with a single entry service delivery network between continuing care and SPD. The second one was to come up with some housing options, 1 or 2 demonstration projects to ensure the community that we were serious about this. So coming up with innovative ways for people with disabilities to have housing. And the third one, oh no, I've gone blank. What was the third one?
You looking at me?
Yeah, I am actually. I am looking at you. I can't remember what the third one was. There's 3. It'll come to me, I'm sure, as I go through. Thanks for your help, Charlie.
You're welcome.
The process that we used was the committee held 5 face-to-face meetings between March and early July of 2013. And during those meetings, we reviewed issue briefs on key areas, considered financial analysis on various key program areas, and we identified 10 core issues and corresponding themes for transforming the system. And I'm just briefly going to show you what those 4 are. I'm not going to go into detail with them, but the key 10 initiatives are person-directed planning and navigation. So that means, giving people choice in terms of how they navigate through a system, that it's the person that comes first. Individualized personal supports and family supports. So rather than people having to fit into a box, you would be asked, what is the services that you require, and try to build services around you. Individualized funding mechanisms. So you would be provided funding, and that funding would follow you. Equal recognition of legal capacity and supported decision-making. Reduce reliance on institutional living and more community-based living. Transformed community-based residential service system. Increased access to competitive employment. Equal access to housing. Comprehensive community-based networks of specialized supports. And the 10th one was a coordinated and integrated disability-specific and mainstream community services. So in other words, you'd have your choice of whether you needed the services of specialized services to enable you to get into employment, or you might be more interested in just accessing mainstream services. So where are we now? Joanne Bernard, the Minister of Community Services, has totally endorsed the report, and plans are now underway to implement it. A meeting of the initial committee was held in January, and we're having another meeting just to update us on plan. And then really that committee has essentially been disbanded, and a new committee will be established. Well, there'll be many committees will be established to get the work underway. Thank you.